We have to start on time so that we can finish on time and allow the next set of speakers to take over. So our course is on on foreign bodies in general, the different presentations and the way we manage them. We have the whole lot of the entire spectrum of presentations in different parts of the eye, and we have with us today the faculty. I'll be one of them. I'm the chief instructor. Can I control it myself, please? I will, yeah. So we have Dr. Satyamurthy. I think he's on the way, yet to arrive. Dr. Kumar is right here. Dr. Aniket Shastri is also here. He was here a couple of minutes ago. He's on the way. And Dr. Apurva Ayachit. So we have a mix of seniors and juniors so that we have a proper perspective of the entire spectrum of both the diagnosis and the management. So the topics that we are going to speak today are on epibulbar foreign bodies, anterior segment foreign bodies, posterior segment foreign bodies in the courts and beyond. And I will be speaking on how not to miss an intraocular foreign body to begin with. So the history taking and examination are very important. Like metal-on-metal activity is something that we have to ask for. A subcongenital hemorrhage or a wound of entry is something that we have to look for. A hole in the iris is pathognomonic of an intraocular foreign body. Cataract, which can be sometimes localized and sometimes generalized, total, can also have its presentation that way. And a track in the vitreous of either blood or exudate, and uveitis or even endophthalmitis. And these are the commonest presentation ways that a foreign body will present with. Of course, this is unmistakable. There is already siderosis, and therefore you know that there is a foreign body inside for a long time. So, but if that was the typical way we take the history and do the clinical examination, sometimes our case may beat your skills. The cases can be so different and atypical that history may not be contributory. Examination too may be apparently negative for foreign body. We have imaging to our rescue. We have X-ray, the good old X-ray which we used to do in the pre-CT era or the pre-MRI era. There is some information on location with the limbal ring that is sometimes fixed to the limbus. It is sutured to the limbus, and the patient is sent for an X-ray of a PA lateral view, PA Waters view, and a lateral view, so that we are able to see the meridian of the foreign body and the location in terms of distance from the limbus, so that we can do a cut-down approach or a intravitreal approach, and thereby remove the foreign body. Ultrasound, of course, by its echo density with shadowing, persistence at lower gain, especially if it's a non-metallic foreign body, you can pick it up with ultrasound, and a 3D construction is possible with some softwares. CT scan in 2 planes is also very accurate, and we are able to localize the foreign body, especially to know whether the foreign body is inside the eye, intraocular or extraocular. Of course, we have to avoid MRI when the metallic foreign bodies are strongly suspected. But one thing I must say here, especially for the postgraduates here, which I learned from Dr. Kumar, is before cataract formation occurs, before dispersion of vitreous hemorrhage, before vitritis sets in, the best way to locate or to confirm the foreign body presence, the invaluable information that we get is from indirect ophthalmoscopy. So don't forget on indirect ophthalmoscopy, no imaging technique is superior to IDO if you can see the foreign body yourself actually there in the eye by clinical examination. Some pitfalls. These are all the typical cases that I was talking about. But what I'm going to talk about in the next 6-7 minutes is about some pitfalls. I'll start with some examples. Unexplained uveitis in a 7-year-old. A 7-year-old comes with a history of recurrent redness and pain in the right eye. His vision is only 3/60. AC cells 2+, vitreous cells 3+, peripheral vasculitis, blood-tinged vitreous opacities. He was investigated for childhood uveitis and vasculitis, all were negative. He was given a course of steroids, vitreous opacification progressed, and therefore vitrectomy had to be planned. But look at the turn of events. What we saw under GA was there was a hole in the iris, a track in the lens, and an intraocular foreign body in the vitreous cavity. This is something that I've shown time and again in different conferences, but it is very important for us not to forget that we have to see these children as a whole like we do in adults. For example, this child was not cooperative. He was a 7-year-old irritable child, could not cooperate for a slit lamp examination. And this is what we were all seeing all along without a proper upper lid retracted, the superior limbus was not at all seen, and therefore we missed the foreign body. What we missed was a hole in the iris, which was the entry site, and a track in the lens. So it is very important that these children are subjected to sedation for the sake of complete examination and maintain a high index of suspicion in all possible intraocular foreign bodies. And retrospectively on history taking, the father was a garage mechanic, and the boy used to visit to give the lunch box to the father. So this is what the story is like, and therefore I think there's a lot of learning from this case. Let's see this other case. History of injury with a stone 2 months prior, history of surgery elsewhere for traumatic corneal tear 2 months ago, and after repair, he had been sent to us for keratoplasty. But what we found was that the patient just had PL, and the view of the fundus was hazy, the pupil was not dilating, there was this corneal opacity which was sutured, which was actually sutured corneal tear, and there was a retinal detachment on ultrasound with a suspicion of a foreign body because of the hyperechoic lesion there with a shadow. And this is what we found intraoperatively. Can you mute it, please? Mute it. So we had to make an incision like we used to do for the intracapsular cataract extractions in the past. And this is how we could extricate or extract the foreign body from the eye, stuck to the ciliary region, a piece of stone which was stuck because it was there for 2 months. It was stuck very adherently, very strongly to the ciliary processes, ciliary body, and the retina, peripheral retina. And we had to extract it by actually cutting the retina as well. So see, you can actually see the retina. And of course, this patient underwent VR surgery. I'm not going to show you that video. Patient underwent VR surgery and could recover some useful vision. This was a case referred as a case of phacolytic glaucoma. You can see that there is a total cataract. There is a small hypopyon, which can be there because of the phacotoxicity of the particulate matter of the cataract. There was no definite history of trauma. There was congestion and total cataract like this. But what we had missed was a corneal tear, which was actually the wound of entry of the foreign body, which was so small and inconspicuous that it could not be seen against the white background of the cataract. So what all that the anterior segment surgeon had to do was to evacuate the cataract, suture the wound, suture the corneal wound, evacuate the cataract, and send to the vitreoretinal surgeon. So the lesson is see the cornea and not just through the cornea. So there is a corneal tear which was missed because of the white background, which was very small. That was the point of entry, site of entry of the foreign body, and therefore you have to look at the cornea and not just through the cornea. This was the imaging that was conclusive of foreign body just before we as vitreoretinal surgeons did the surgery. So this was a case referred to us as a case of heel chororetinitis. Patient had 3/60, thoroughly investigated and worked up for uveitis and given steroids for 2 months. I'm sorry about the photograph, it is quite dull, but I'm sorry. So what actually the lesion was, the video is not playing, can you help me? Yeah, it's playing now. This is an old video, and that is why we have a limited field there, a 30-degree field. Actually, it was not a chororetinitis scar, it was an encapsulated foreign body, and you can see it was right at the macula in a capsule, which later got absorbed and the patient recovered 6/18 vision from 3/60 to 3/60 by 2 months. It had improved to 6/18, which is very, very heartening. So this is a case of floaters with 6/6 vision, N6 vision, referred to us as a case of active toxoplasma retinochoroiditis, treated with chlorotrimazole for a month in vain, of course. Patient came to us with floaters when the floaters increased, and there was paracentral scotoma. So what exactly was the thing behind was, I'm sorry, where is this? So this was also a case of foreign body. You can see that on imaging, we discovered that there was a foreign body, and this patient had to be explained all the pros and cons of the surgery because it was so close to the macula. Patient had 6/6 vision, and you can imagine what if there was an accident during surgery or a complication during surgery, but this patient did very well. The foreign body was removed from its site of lodgement and finally removed the forceps. So this was a mine worker, injury in a mine blast activity, presented 3 months after the injury, PL only vision, total cataract, ultrasound was negative for any foreign bodies, but vitreous hemorrhage was seen, and X-ray was negative for foreign body, and this is what we found on table. When we did the vitrectomy for vitreous hemorrhage, there was this stone particle, which is usually non-radio opaque or radio lucent or radio transparent, and therefore could not be seen on either CT or X-ray. And this is how we removed it with an extrusion because it had a rough surface, could not be held. We did not have the basket forceps at that time. This again is an old video, maybe 12 years ago, 12 years back. This case was done, and it was removed from the translimbal approach. So this was a 33-year-old female working in the fields, and a thorn injury that she had sustained while traveling the tractor at night while coming back from work. All that we could see was a brownish discoloration under the conjunctiva. And when we explored, we found that this was actually, when we opened the conjunctiva, attacked the muscles and saw this, the brownish discoloration was actually the tip of the long organic foreign body or a thorn that had gone right into the vitreous cavity. So this is something that can happen and can be mistaken for just a melanoma, melanosis of the conjunctiva. Patient was not very symptomatic. Finally, I always like to show this. Let me show you the one on the right. I'm sorry. So this is an intravitreal foreign body. That's actually a nematode, which was live, and it's not a big deal to remove this. And please play the slide on the right now. Please play the video on the right. Some of you seem to be controlling more than me. Not this, the next one. Yeah. So this was a subretinal foreign body in a lake of retinal detachment, swimming in a lake of retinal detachment. A subretinal biologic foreign body or a nematode. You can see that I had to do a retinotomy to remove this nematode from the subretinal space with the cutter itself, with the vacuum of the cutter, and regurgitate it into the vitreous cavity, from where it was removed in a more controlled manner with the flute needle. Okay. So this is the foreign body at the end of the nematode, which came out at the end and was still live. So to summarize, detailed history taking is important. Occupation is very, very important, not only of the person who has been affected, but also of the family members. A careful slit lamp and fundus examination. Always make an attempt to see the foreign body with the IDO, and use of imaging to confirm, rule out, or localize a foreign body is very, very useful and should be done. A high index of suspicion in all trauma cases, needless to say, is very important for any unexplained uveitis or endophthalmitis. Thank you very much. So I would invite questions now, or can we have it at the end, whatever the co-panelists, co-instructors can please come over here now that we have enough audience.